Hi everyone, we are moving on to further topics in anatomy of pulp cavity. So we'll study topics like root canals, various root canal classifications, isthmus, apical foramen, accessory and lateral canals, and we'll also talk about influence of aging on pulp cavity. So here on the screen you can see internal structure of tooth. This innermost part, this part is pulp cavity. Pulp cavity is central cavity present within a tooth enclosed by dentine except at the apical foramen. So this whole structure is pulp cavity. We have discussed this in previous video. Pulp cavity is divided into pulp chamber and root canal. Pulp chamber is, you can see, this is upper portion present in the upper section of tooth, and root canal is present on the lower section of tooth. Now we'll just study pulp chamber parts in brief. So this, you can see the labeling roof of pulp chamber, which is covered by dentine occlusally, and you can see floor of pulp chamber here. So this floor of pulp chamber, which is parallel to the roof of pulp chamber, and this orifice from chamber to canal, which is uh, also called canal orifice, which are openings in the floor of pulp chamber leading to the root canals. So canal orifices, this is openings present on the floor of pulp chamber. These are not separate structures. These canal orifices are continuous with both the pulp chamber and root canals. I can see this portion is root canal. So what is root canal? Root canal is the portion of the pulp cavity from canal orifice to the apical foramen. So this you can see from canal orifice. It is from canal orifice to apical foramen. This portion is root canal. Root canal divided into three sections: coronal part, middle part, and apical third. The coronal part of root canal present coronally, and apical third present on the apical portion of root. So here comes the components of root canal. So we'll just refer this as figure first and this one as second. So first one is apical third of root, and second one is buccal view of mandibular first molar. The root canal components includes apical foramen, accessory canal, and lateral canal. These are main root canal components. If we zoom this figure, this is main root canal, and these are the branches of main root canal, which is also called accessory canal. So accessory canals are the branching of the main root canal occurring in the apical third or furcation area of root. So in molar, here accessory canals occurs on the furcation area of root. So accessory canals are the branching of main root canal occurring in the furcation area or apical third of root. Now this is lateral canal and this is main root canal. So lateral canals are also the branches of main root canal which extends only on the lateral side of root. Okay, here in molar, this you can see here, lateral canal extends laterally. So accessory canals occurs anywhere, like maybe in the apical third or furcation area, but lateral canals occurs only on the lateral side of root. Okay, so in brief we can say that all lateral canals are accessory canals, but all accessory canals cannot be lateral canals. I'll repeat that all lateral canals are accessory canals because accessory canals can occur anywhere, but all accessory canals cannot be lateral canals because lateral canals occurs only on lateral side of root. Apical foramen, this is apical foramen. Apical foramen is an aperture or present near the apex of root through which various blood vessels and nerves enter or leave the pulp cavity. Accessory foramen. Accessory foramen is also a small opening which is present on the accessory and lateral canals in the root surface. So apical foramen is present on the apex of root, and accessory foramen present on the accessory and lateral canals. Okay, accessory foramens are just the openings present on the accessory and lateral canals in the root surface. Apical delta, this triangular shaped structure, this is apical delta. So here you can see Y-shaped branching. Apical delta is formed by Y-shaped branching. So apical delta, which is a Y-shaped branching of the root canal present near the apex of tooth, These apical delta branches allows free passage of blood vessels and nerves from the periapical compartment to the pulp tissue. Apical delta is most commonly found in maxillary second premolar, mandibular second premolar, and mandibular lateral incisors. So you can also see apical delta in radiographs. Here we can appreciate apical delta in radiograph. These are Y-shaped branching, which allows free passage of blood vessels and nerves. And this triangular structure is apical delta, okay? And these are present near apex of tooth. Root canals can be straight or curved. If we talk about the straight root canals, you will barely find straight root canals extending the entire length of root, because either a constriction is present before the apex is reached, or more commonly curvature is present. So straight root canals are very uncommon. Now, if we talk about the curvature of root canal, here in radiograph, you can see this root canal is all straight with very slight curvature near the apex. So this is a straight canal extending with minimal apical curvature. So here in this radiograph, you will see a gradual curvature of the canal with a straight apical ending. So here you will see a very slight curvature of canal in the middle with straight apical ending. So here you will see this complete canal is slightly curved. A gradual curvature of the entire canal can be seen here. In this radiograph, you will see a very sharp curvature of the canal near the apex. Okay. Here you will see a very severe, a very extreme curvature of canal near the apex. Okay, so before moving ahead, I want you to know that curvature of root canal can be measured through various methods by determining their angle and radius. The fact is, the greater the angle of curvature, the greater will be the complexity of the case. So here in figure A, you will find various forms of curvature: mild, moderate, last one is a very severe curvature. And in radiograph, you will notice a very severe or greater degree of curvature is present. So the more the degree of curvature, the more it will be difficult to negotiate with endodontic instruments. Now suppose we are dealing with root canal, which is very narrow and its curvature is 20 degree. So it will be very difficult to handle this kind of root canal. Whereas there is another case in which the angle of curvature is 30 degree, which is greater angle of curvature. So it may pose some difficulty, but the root canal here is not narrow, it is wide. So the case is the angle of curvature is 30 degree and root canal is wide. So because of its wideness, the root canal can be negotiated with endodontic instruments. So success of working out in narrow curved canals depends on the following. First one is degree of curvature, and as we know that the greater the degree of curvature, the more will be difficulty while treating a case. Size and different types of constriction of root canal also play a role in success of negotiating in narrow curved canals. Size and flexibility of the endodontic instrument's blade, and obviously skill of the operator is very much important while dealing with narrow curved canals. In most cases, the number of root canal corresponds with the number of roots, but in some cases, a root may have more than one canal. So there are some exceptions. Mesial root of mandibular first molar almost always has two canals, and distal root of mandibular first molar periodically has two canals. So here in radiograph, you can see that this is the radiograph of mandibular first molar. Both mesial root and distal root of mandibular first molar has two canals. Another example is mesiobuccal root of the maxillary first molar frequently has two canals. So this is occlusal view of maxillary first molar. which is having three roots: mesiobuccal root, distobuccal root, and palatal root. And you can see here mesiobuccal root has two root canals, MB1 and MB2. Another example of tooth having additional canals are mandibular anterior and premolars. So here in radiograph, you will see this is premolar, which is having two canals, and these are mandibular anteriors with two canals. So the pulp cavity of a mandibular anterior or premolar tooth may be bifurcated to present two separate root canals. Understanding of root and root canal morphology is essential for effective non-surgical and surgical endodontic treatments. The external and internal morphological features of roots are variable and complex, and several classifications have been proposed to define the various types of canal configuration that occur commonly. So, various classifications of root canal configurations are as follows: Vertucci's classification, Weine's classification, and Joe et al. Classification. Vertucci classified root canal morphology into 8 types. So here is the diagrammatic representation of 8 different types of root canal configuration. Type 1 is single canal extends from pulp chamber to the apex. So configuration is 1, a single canal present. Example of tooth following type 1 is mandibular second premolar. Type 2, two separate canals leave the pulp chamber and merging short of the apex to form single canal. Configuration is 2-1. Example of tooth, mesiobuccal root of maxillary first molar. Type 3, single canal leaves the pulp chamber and dividing into two in the root. The two then join to exit as one canal. Configuration here is 1-1. Example of tooth following type 3 is mandibular first premolar. Type 4, two separate canals extend from pulp chamber to apex. Configuration is 2. Example of tooth, mesial root of mandibular second molar. Type 5 is single canal leaves the pulp chamber and dividing into two separate canals just short of the apex. Configuration here is 1-2. Example of tooth, mandibular first premolar. Type 6, two separate canals leaving the pulp chamber and merging in the body of the root and dividing again into two distinct canals before the apex. Configuration is 2-1-2. Example of tooth, mesial root of mandibular first molar. Type 7, single canal leaving the pulp chamber and dividing into two and then merging in the body of the root and again redividing finally into two separate canals short of the apex. Configuration is 1-1-2. Example, mandibular first premolar. Type 8, three separate canals extend from the pulp chamber to the apex. Configuration is 3. Example of tooth follows type 8 is mesial root of a mandibular first molar. So a small trick to learn these configuration is that the first digit is alternatively 1 and 2 up to type 7, beginning with type 1 in type 1. So here you can see type 1. First we will zoom this. First digit in type 1, type 2 first digit is 2, type 3 1, type 4 2, type 5 first digit is 1, type 6 again 2, type 7 1, and type 8 is 3, which is not following this trick. Okay, so type 8 is exception for this. So up to type 7, so in type 1 you will see configuration 1, type 2 first digit 2, type 3 again 1, and so on, and type 8 is 3. Okay, which is an exception. And another thing to be noticed in this classification is first 3 types ends with single canal at the apex, whereas the next 4 types ends with 2 canals at the apex, and the 8th type ends with 3 canals at the apex. So this is how easily you can remember this classification. Another classification is Weine's classification, where Weine's classified root canal configuration into 4 types. Type 1 is single canal extending from pulp chamber to apex. So configuration here is 1. Type 2 is two canals leaving from the chamber and merging to form a single canal short of the apex. So configuration here is 2 1. Type 3, two separate and distinct canals from chamber to apex. So here the configuration will be 2 2. And type 4, one canal leaving the chamber and dividing into two separate and distinct canals. So configuration here will be 1 2. Another one is Joe et al. Classification based on canal cross section. According to Joe et al., canals can vary based on their anatomy cross sectionally with round, oval, flattened, irregular configuration. Now comes the isthmus. Just keep aside root canal isthmus for now and try to understand the meaning of isthmus. So this is this is what a very narrow strip of land connecting two larger land, and the water is present on both sides. So isthmus is like a bridge connecting two areas, and this bridge like, or you can say a narrow strip of land, has also separated two water bodies. Now, talking about root canal isthmus. So, proper management of canal isthmus is considered very important factor for successful endodontic treatment. Root canal isthmus is a narrow ribbon-shaped communication between two root canals. So, this is how you will see it anatomically. Okay, I mean a very narrow ribbon-shaped communication between two root canals. So, just look at the diagram here. So, this is first, and this is second one. So in first you will see a very narrow communication present inside a canal or within a canal. And in second one you will find a narrow faint communication between two canals. So I mean two canal interconnections are present between mesial and distal canal here. Now just look at the classification of isthmus given by Kim et al. Type 1 to 5. So these are the cross-sectional view. Type 1 is a very faint or narrow communication present between two canals. Type 2 is complete isthmus with a very clear connection between two canals. Type 3 is a complete but very short isthmus between two canals. Type 4, complete or incomplete isthmus between three or more canals. And type 5 is two or three canal openings are present without visible connections. Now we'll study apical foramen in detail. So what is apical foramen? It is the opening at the apex of the root of a tooth through which the nerves and blood vessels enter or exit the pulp cavity. Now here in the image we have, this is funnel shaped opening, okay, with the major foramen here. This apical foramen is the major foramen, and minor foramen, this minor apical diameter is the minor foramen, which is also called apical constriction. So this apical constriction, which is 0.5 to 1 mm within the anatomical apex. And then we have pulp, dentine, cementum, and CDJ, which is, that is CDJ is cemento-dentinal junction. Here is the anatomical apex, and here is the radiographic apex. Radiographic apex is the apex formed or seen in radiograph is radiographic apex. So as we know that in young incompletely developed teeth, the apical foramen is funnel shaped with the wider portion extending outward. So this is like wider portion extending outward. Okay. The mouth of the funnel is filled with periodontal tissue. Here just suppose this is a periodontal tissue that is replaced by dentine and cementum later. So this periodontal tissue will be replaced by dentine and cementum as the age progresses. So as the root develops, the apical foramen becomes narrower. The inner surface of the root apex becomes lined with cementum, which may even extend for short distance, 1 mm or so, into the root canal, meaning that cementum deposition at the apex extending the deposition inwards as the cementum deposited inwards, As a result, the CDJ, which is cementodentinal junction, shifts inwards. Therefore, cementodentinal junction does not necessarily occur at the extreme end of the root but may occur within the main root canal. Here is the cementodentinal junction. So this is not present at the extreme root but is present short of the apex. So shaping, cleaning and obturation should be done till cementodentinal junction, which lies within the canal just short of the apex. There is no need to extend the procedure till anatomical apex. And some studies recommended that root canal obturation should end approximately 0.5 to 1 mm short of the anatomic root apex. The apical foramen is not always located in the center of the root apex. So here in diagram you will observe that anatomic apex is located here. This is the anatomic apex. This is the location of anatomic apex, and apical foramen is away from the anatomic apex. This is the apical foramen, which is away from the anatomic apex. So apical foramen may exist on the mesial, distal, labial, or lingual surface of root. In 17 to 46% of cases, the apical foramen coincides within the anatomical apex and is located at 0.4 to 0.7 mm away from the anatomic apex. And in few cases, the apical foramen has been found 2 to 3 mm away from the anatomic apex. Now just take a look at this diagram. Here you will find various courses taken by root canals and locations of apical foramen. So if we zoom this, these opening are apical foramen and this is root apex, okay, in each of these. So suppose this is figure A, this is B, this is C, and this is D. In figure A you will find a curved root canal with the apical foramen distant from the root apex, okay. In figure B also you will find a curved root canal with the foramen near the apex. Here is the apex and here is the foramen very near. In figure C, you will find constricted root canal as the apical foramen is approached. That is, the apical foramen in figure C is directly opening at anatomical apex. Okay. And in figure D, you will observe double curvature of root canal with foramen at a distance from the root apex. Double curvature of root canal with the foramen. This is the foramen and this is the root apex. Okay. So these are the various courses taken by root canals and locations of apical foramen. This is a scanned electron micrograph of the apex of the mesial root of a maxillary first molar, showing apical foramen and multiple accessory foramens. So this is apical foramen. What is apical foramen? Is an aperture opening present near the apex of a root through which various blood vessels and nerves of the pulp enter or leave the pulp cavity. And these small openings are accessory foramen. Okay, there are multiple accessory foramens present. Accessory foramens are the openings of the accessory and lateral canals in the root surface. Okay, so this table gives the approximate time of eruption of the teeth and calcification of the root apices. So central incisor, which erupts at around 6 to 8 years of age. Next comes the lateral incisor, which erupts around 7 to 9 years of age, and canine erupts around 10 to 12 years of age. Then first premolar at 9 to 11 years, second premolar at 11 to 12 years, first molar at 5 to 7 years, and finally second molar at 12 to 13 years. Root calcification is completed 2 to 3 years after eruption of tooth, and this is a general rule that a root apex is completely formed about 2 to 3 years after eruption of tooth. For example, eruption of central incisor tooth occurs at 6 to 8 years of age, and so calcification of root apex of central incisor will be completed after 2 to 3 years of eruption of tooth, which is 10 to 12 years. In same lateral incisor tooth erupts at 7 to 9 years, but root calcification will be completed at 11 to 12 years of age. And same as in canine, the eruption of tooth occurs at 10 to 12 years of age, and calcification of root apices of canine will occur after 2 to 3 years, that is 13 to 14 years of age, and so on. And these values. Okay, so what is lateral canals? Lateral canals are the branches of main root canal which extends only on to the lateral side of root. These are lateral canals, okay? And accessory canals are the branching of the main root canal occurring in the apical third or furcation area of root. So here you will see these are accessory canals, okay? And what are accessory foramina? Are the openings of the accessory and lateral canals in the root surface. So these lateral canals and accessory foramina are intrinsic and essential part of the normal pulp cavity. Now, how these canals, lateral canals and accessory foramina are formed? So what happened is when periodontal vessels bend or loop around the root apex of a developing tooth and often become entrapped in Hartwig's epithelial root sheath, resulting in formation of lateral canals and accessory foramina during calcification. I'll repeat, when periodontal vessels bend or loop around the root apex of a developing tooth and often become entrapped in Hartwig's epithelial root sheath, resulting in formation of lateral canals and accessory foramina during calcification. So this whole event of formation occurs in the apical third of the root, and that is why a high incidence of lateral canals and accessory foramina are observed in the apical third of the root. The reported incidence of lateral canals ranges from 27.4 to 35.5%. Just have a look at this radiograph on screen where you will find an obturated tooth. Here, we'll zoom this. So, this is an obturated maxillary molar. So, here you will notice that there is the penetration of sealer into the accessory canals in mesiobuccal root. This is the mesiobuccal root, and you will notice here the penetration of sealer into the accessory canals. So this penetration of sealer into the accessory canal is considered to be acceptable feature, as sealer prevent the colonization of residual bacteria into the dentinal tubules because of their antibacterial properties. But over penetration or over obturation of sealer beyond apex is prevented. These accessory canals do contain pulpal tissue, okay, and as the age increases there can be obliteration of these accessory canals and lateral canals by deposition of cementum or reparative dentine. So with progressing age the accessory foramina decreases in number because of calcification of their soft tissue present within, okay. So these are just a short description about lateral canals. Influence of aging on pulp cavity. So the size and shape of pulp cavity changes with age. In young age or in young tooth, you will observe here in diagram that these are the pulp horns. These pulp horns are quite long. This pulp chamber is large, okay, as compared to the old tooth. Root canals are wider here, apical foramen are broader here, okay. And the dentinal tubules of young tooth are wider, regular, and filled with protoplasmic fluid. Now, as the age progresses, these pulp horns recede. Pulp chamber becomes smaller in height. You can see here in old tooth diagram, okay? Root canals becomes narrower by deposition of secondary and reparative dentine. Apical foramen or major diameter becomes wider, that is, width of foramen opening increases due to deposition of dentine and cementum. And also, it is noticed that with increasing age, apical foramina deviate from the exact anatomic apex. It may exit on mesial, distal, labial, or lingual surface of root slightly eccentrically. Apical constricture or minor diameter, which is located 0.5 to 1 mm short of the apical foramen, becomes narrower with advancing age. Peritubular dentine, which is highly mineralized dentine that surrounds or encloses dentinal tubules, get deposited. This deposition of peritubular dentine results in narrowing and obliteration of dentinal tubules in older people, leading to the formation of sclerotic or reparative dentine or tertiary dentine. with advancing age. Okay, so during any severe dental injury, which is reaching up to the pulp, or any external noxious stimuli, there will be regeneration of dentine from new odontoblast like cells, which is called a reparative dentine. This reparative dentine is more atubular, that is, may lack dentinal tubules, and their water or moisture content of dentine also decreases. Lateral canals incidence also decreases as the age progresses due to deposition of reparative dentine or tertiary dentine, or cementum formation and calcification. Very important to know that endodontic treatment of young teeth does not affect normal eruption. So, root canal treatment of primary molars will not hinder the normal eruption of young permanent teeth.